So my question for you is, the doc who says, I've been practicing medicine the way I've been practicing it for 20 years, and it works great. So why is this going to make me a better doctor?
Wow, that's a really complex question, okay? Now, in the other part of my life, I've spent the past 5 to 7 years working at the American Academy of Pediatrics on the Brave Futures Guidelines. And one of the painful things that we've had to learn about ourselves is that just because we think we're doing really well doesn't mean that we're necessarily doing what is appropriate to 2011. Because certainly in pediatrics and adult medicine too, things change. There's this whole new concept out there called evidence, and we have to pay attention to it. And the evidence drives what sort of screenings we're going to do, what kind of testing we're going to do, what our recommendations are going to be to our patients. So many of us found when we began the Brave Futures Project that yes, we were good practitioners. We felt good about what we did. We were valued by our colleagues and our patients. But on the other hand, there's always room for improvement. You know, medicine is not a static field, it's a changing field. So I think that on the one hand, most of us who think are doing well, those of us who are truly doing well also know that we have to embrace change. We know that change is necessary if we're not only to do it well, but do it up to date and well. I think the second thing is that whether we like it or not, the system of healthcare is changing. And the way that we have traditionally interacted with hospitals, with laboratories outside of our own offices, in terms of sharing information and getting information, clearly that's changed.
So let me just ask you again about the productivity piece of that, because what you said earlier contradicts a little bit what we hear a lot, that docs do have to back off on their productivity and cut back on patients they see for sometimes many weeks, and you did not experience that.
No, we did not have that experience, and part of that is because we had the opportunity to plan for it. Planning can take a number of steps. I think the first step of planning there is plan carefully your choice of a system. We were able to choose a system that was really designed for small primary care practices with strong pediatric background, and a system that mimicked what we did and did not require us to mimic what it does. And when you talk about people who are having difficulty adjusting, it's usually because they're having to change to match the new system. And frankly, I think there's a lot of good systems out there, and you ought to be able to find one that matches you better.
So how do you manage to interact with the patient using a computer?
Okay. Well, as you
Then
see,
I'm the patient.
Yeah, you're the patient, I'm the doc, and as you see, my laptop, oddly enough, is on my lap. I find this awkward because I'm higher, and this is probably because it just suits the way my arms are, but I happen to like doing this, okay? We sit on stools, not on chairs, and you know, the office is set up in a way that I have this very comfortable wall to bang into. But you know, I can work here and look at you, and I do have to look down because when you're finding a template that requires a click rather than a letter, you've got to do that. But you're really you're looking up and down anyway. Frankly, when you're writing on a chart, you're doing the same thing. You know, you're looking at the patient, you're formulating opinions, you know, during the history taking, but you're also, your eyes, you know, we're trained to let our eyes and our ears and our nose, you know, see what else is going on in the room. So we're sort of used to flipping our eyes around. So for us, for me, for my partners, this really works well.
How do patients react to this when they see the computer? Do they like it, or are they concerned about it?
I haven't had anybody say anything. I have had 1 or 2 people who looked skeptically at it at first, but that has completely gone away now. The only time that I tend to acknowledge its presence is if I'm doing a parent conference, usually about a behavioral health or mental health thing, where I think it's important to acknowledge why I'm taking notes. And I think it's important to do that anyway when you're talking about behavioral health, because these are usually issues of a child's discipline or behavior that parents are sensitive about. So you want to say, well, I'm taking notes here so that I have a record of what we're talking about, and so I will stop and type every once in a while. But that's the only time that I feel compelled to acknowledge it, because I would have done it when I was doing a paper chart anyway.
So how, from check-in, check-in starts here, patient arrives here, how does the EHR get used right at the beginning?
Okay, so when the patient comes in and checks in with Kelly and says, "Hi, I'm here," she marks in her own computer terminal that the patient has arrived. That sends a message to all of us that the patient is here. If I'm sitting back in my office and I have my screen lit up, I'll know that patient Smith has arrived, okay? My nurse or assistant, who are working usually in the lab hub area, also get that message. And when they're ready, they go take that patient down to a room, and they write in the computer which room they're in. And now the icon says "with nurse" in room 1. And
when are those two things helpful to you as a doctor?
Well, it's helpful to me first thing in the morning when I'm sitting back there doing paperwork, trying to catch up on phone calls, knowing whether I have a minute to do 2 or 3 more pieces of paper or 15 minutes to get involved in a long phone call. So before I'll place a phone call to a parent that I know is going to take some time, I'll see if my first patient's here yet, because I don't want to put myself behind for the whole morning by doing that. You follow me? Once the patient's ready for me, it says "ready for provider." And I walk in the room and I click that icon, and now it says "with provider." And when I'm done, I click it says "ready for nurse," and the nurse knows that they're ready now to give the immunization, to ever follow up. Or if there's nothing to be done, that we're done with the patient, I click "end visit."
So I do notice that you still have paper charts.
Mm-hmm.
Will they ever go away?
Well, if we get the camera to stop looking at me and look at you, it'll also see that one of the, look at this. Look at, where did those charts go? That used to be filled with charts.
Okay.
These charts, we've completed the scanning of. They're all now electronic health record.
So describe the process then. So somebody's new to this EHR thing. How do they begin taking the paper chart and putting it into an electronic format?
Well, I think that depends on which system you have, in terms of which computer vendor you're using. But they both require you to make some decision about what you're going to do with the paper. And what we have done is simply scan the existing chart in bulk.
The entire thing?
The entire thing. It's really, once you've started the process of scanning, whether you're scanning 10 pages or 15 pages, it's nothing in terms of the data storage. And in terms of the time involved, you're putting a pile in and just sort of watching them do it. So, but this is not one of your highly reimbursed employees either. This is somebody you hire part-time.
Do you find yourself going back and looking at those scanned documents?
I'm glad you asked that question, because rarely do you, okay? And that's why I don't mind them being scanned in bulk. When you do have to go back, it's tedious, and it's probably more tedious than going through a paper chart, because you're used to the paper chart and you know where to flip through. Whereas if you're scanning, you're going to have to go through all those other papers that are there. There's not going to be any sort of hint based on, pagination. But the charts are all set up in the same way. They're all scanned the same way, so I know basically where to jump to look for an ultrasound, for example. You don't do it very often. On the other hand, you've got to keep the medical record for medical legal reasons, medical liability reasons, and you've got to keep the patient record because it's the patient's record. Until they reach the age of majority plus 3 years. So you've got to have some record of it, and since you're not going back to it very often, this is a great way to keep it.
So a lot of physicians are really concerned about the cost of an electronic health record and whether it's worth the investment. What's your opinion on that?
Well, I think it is. There's cost to do it, there's cost to not do it. Is it worth the investment? Absolutely. Well, first off, it's going to pay back with meaningful use. It's going to, if you have a computer system, you well know this, that does certain things in an appropriate way to satisfy the federal government, then you're entitled to this lovely bounty over the next 4 years. And that will pay for the system that we have, probably a little bit more. How cool is that? This practice was recently certified as a medical home by the NCQA process. We really probably could have done it without an electronic health system, but it would have been much harder. So there's a cost to not do it. If we hadn't been an electronic system, I'm not convinced that we would have gotten NCQA level 3 certification, which is the best. I've been told it's very hard to get above level 1 unless you have an electronic health record.
Which leads to Blueprint.
Leads to Blueprint, because for each one of those Blueprint patients, now that we're an NCQA certified medical home, we get a per patient per month reimbursement.
It's fairly substantial too, isn't it?
Yes, indeed.
Yeah.
Yes, indeed.
So cost for doing it, but a payback for...
A payback for doing it, yeah. And again, I think that when we looked at the various systems out there before we made our decision, there was a wide range of cost. One system I looked at for a two-person, two pediatrician and 1.5 FTE nurse practitioner, which would be total four providers. One system wanted $90,000 just for licensing. And I didn't even bother to ask them what are the monthly costs going to be, because that was more than I was ever going to consider spending. And there's a great variety. You do get what you pay for, but you want to make sure you're paying for what you want and not for what some other type practice wants. You know, surgical practice can have different needs than a primary care practice. The other thing that we noticed is that some vendors tend to put a pretty high upfront licensing charge and then a service charge that's lower. Some vendors have a fairly low licensing charge but a larger service fee in the long run, because that service fee is attached to strong service and is attached to frequent and continuous upgrades of the system based on feedback from practitioners, our practice and others. We chose the latter. So our actual cash outlay early on was really not that painful. Our cost per month is probably a little bit higher than practices, are paying otherwise, but we're getting a whole lot of service for that. So I think you should look critically at what's being offered and remember that those contracts and those dollar figures are not apples for apples. They're different, and you have to think about the long term.